Perfect. So we're lucky to have one of our residents, Dr. Elsire Boulanger Laborit, is a PGY1 in hematopathology. And so she just recently finished transfusion medicine teaching rotation here at BGH, and we're grateful to have her present on ABO discrepancies, where she'll be going over a review and then also have a lot of practice cases. So please pay attention and be excited here for our resident, because there are some polls that you'll have to answer about ABO cases. And the caveat on that is I've never hosted polls before, so we'll see how it goes, and we're going to keep our fingers crossed that I can figure this out. Okay, I'm going to stop sharing my screen, and Elsie, go ahead. You can share yours.
Hi, everyone. Hi, Dr. Markham. Thank you for the presentation and welcome, everyone. I'm just going to share my screen. Okay, can everyone see this?
Yes, perfect. Yeah. Thanks,
Okay.
Elsie.
We are going to talk today about ABO discrepancies. So first, let's start with the ABO blood group system. This discovery was made in the 1900s by Dr. Karl Landsteiner. This was an Austrian scientist who discovered the ABO. What he just did is that he saw that some people had certain type of blood that agglutinated with some kind of serum and others didn't. So this was a discovery of the ABO types, and this granted this doctor the Nobel Prize of Medicine in the year 1930. So this is the father of the ABO blood type. The important here is that we have the ABO phenotypes. We have 4 ABO phenotypes, which can be A, B, A, B, O. But for the genotypes, then we have more cases because there is a genetic inheritance of the ABO phenotypes. It's codominant, so one from the father, one from the mother. So we can have 6 types. For A, the genotype can be either AA or AO. For B, BB or BO. AB, just one A, one B. And for the O, nothing. So there's no A or there's no B antigen. There is another thing, that the people who have the A antigen, they present antibodies to the antigen that is not in their blood. So in this case, it will be anti-B. If somebody has a B antigen, this person will have an antibody against anti-A because this is naturally occurring. So these people or everybody will have antibodies against those antigens that they were not born with. So with the AB, there's none. And for the O type, there will be anti-A and anti-B. This is naturally occurring, and people don't need to have any exposure to the antigen previously to develop this antibody. It's important to know that the ABO locus has 3 main allelic forms, which is AB and O. The A allele encodes a glycosyl transferase that produces the A antigen, which is the N-acetylgalactosamine. This is the immunodominant sugar. For the B, this same H antigen has a special glycosyl transferase that creates the B antigen, which is called the D-galactose. And for the O, we have the H antigen unchanged. So just to explain it better with a photo, we have here an schematic picture. So for the H locus, which will be this one at the bottom, we have the H antigen that is located in the chromosome 19, and it encodes a fucosyl transferase that produces the H antigen on the red blood cell. So what we have is the fucose, which is an alpha-1, alpha-2 fucose. This is just the H antigen unaltered that is present in the red blood cell. But for the person who expressed the A antigen, we are going to have present an N-acetylgalactosamine at the end of the fucose terminal. And this is going to be giving the A blood type to the people. Instead, for the B antigen, it's going to be, we are going to have the galactose. So this is the difference. People with AB blood type will have both expressions, but people with O type will have just the H antigen unchanged, so it will end over here. Interesting, there are some people who doesn't have H antigen at all, but these cases are very rare, and these are called Bombay phenotype because they were discovered there in that city. So these people won't have H antigen at all, but those are rare cases. For the routine ABO testing, we are going to need some special anti-sera or reference cells to do forward typing and reverse typing. So how do we do this? We need two methods to confirm the ABO. So we start with the forward typing. For this, we just have to ask ourselves, what is the blood type or what is the antigen present in the red cell of the patient? So to do it, we have to test the recipient's red cells with the reagent anti-A and anti-B. We are going to mix 1 drop and 1 drop, and we are going to see if the agglutination occurs. If the agglutination occurs, with anti-A, we can say that this person has the antigen A, the B, if it's with the anti-B, or the O if it doesn't happen at all. And we could either say that the patient has AB if it happens with both. We need to grade the agglutination, and to do the grading, we are going to have a scale from 0 to 4, and this is how we classify it. If there's no agglutination at all, we can say that the response is 0. 1 cross when we can see little clumps. 2 when there are more obvious agglutinated red blood cells. In the 3, there are some loose clumps with some obvious ones, and in the 4 cross reaction, there is a big clump. And this is the strongest reaction that we have with this, which is the tooth method. But now we need a reverse typing just to confirm or to be just the control that of the forward typing that we are doing. Because of the ABO type, if we have a recipient, it's going to depend what type of blood this patient is going to receive. Or if this patient is a donor, or if we have the case of a donor, we need to be certain of the blood type. In cases of the donor, we just test for their blood type twice. They test it in Canada at the CVS, and then they test it at the hospital when they receive the unit, just to be 100% sure. For the reverse typing, we are going to use the plasma. So we are having here an EDTA blood tube. Just the plasma is what we need, and we are going to test the recipient serum with the reagent red cells to determine what antibodies are present in the patient's serum. So as I say, this is just to serve to act as a control for the forward type. Naturally, patients with A will have anti-B, B will have anti-A, AB neither, O we have both. And we have other methods to confirm the forward typing or the reverse typing. We have this at the middle, that is the tooth type that I was explaining previously, but we have also the gel. And the gel is very used. I could say that is the most common use at the hospital right now. This is the one that we use mostly at VGH, but we still can use the tube for manual control. The machines automatically will do the gel. And for the gel, we have this representation, whereas negative reaction will be 1, 2, 3, or 4. And we also have a solid phase that we used to have it in Vancouver General Hospital, but now we don't have it anymore. And this is the contrary of the tooth. So it's just important to know that if we ever see this in another hospital, then this is the reaction. For the 4 cross, we won't see a bottom, so it's the contrary of the tooth. But the two most common that we will see will be the tooth and the gel. Now, for the routine ABO grouping, we can be certain with these reactions what kind of blood type the patient will have. This is more or less what I was explaining. For the forward type, we will take the red cell of the patient and we'll mix it with anti-A or anti-B. But for the reverse typing, we are going to get the plasma of the patient and we'll see if the patient will have agglutination or not. So if we have a patient group O, the patient won't have any reaction with the forward type, but with the reverse type, we will see that there will be agglutination with the A1 cells, with the B cells, and we can be certain, or we can say that this patient is group O, which is the most common blood type in European and African ethnicity. So I have the percentage here. For this, then let's go through an example. We have this case here, and I'm going to ask the audience, what blood type will this patient be? We can release the first poll. Okay, so we can choose what is the blood type of this patient? And let's see what people say, what the audience say about this.
You probably can't see those results, hey, Elsie? Okay, so
I can't. No.
okay, I'll just give a few more seconds for anybody else. We have about half the people participating. Okay, here we go. And share. Can you see that?
Yes. Okay, we have 92% says this is B positive, 4% A positive, 4% B negative. So in this case, we are having B positive because we're having these two first are the forward typing. We have a reaction with the B, so it's the red blood cell of the patient with the anti-sera B. It's a 4 cross. And then this is just the B, so this will be positive, B positive. And we have the control should be negative, that is the same blood of the patient, red blood cell with same plasma of the patient. But with the reverse grouping, we are having a reaction with the A1 cells, which is expected with the B positive patient type. We are having that patients with the B antigen will have naturally occurring antibodies against A and won't have antibody against their own cells. Now we have here another case to do another poll. What is the blood type of this patient? And we can launch the second poll. And we can see the results. We could share the results. Okay, very good. O positive, we are all very clear that this is a typical O positive case. And for the last case that we have here, what will be the blood group and type of this patient? And now we can share the results. A positive. So we are very clear with this case. It's a typical A positive. And now that we know about it, we can start talking about ABO discrepancies. Just the definition. A discrepancy exists when the results of the red cells do not agree with those of the serum test, usually because we are having an unexpected negative or positive result in either the forward typing or the reverse typing. When a discrepancy is encountered, it is very important to solve it. It must be recorded, but we need to solve it to know what is the real type of the real blood type of the patient, because we cannot transfuse the patient with the blood type if that we believe, let's say we believe this is A positive, we cannot transfuse the patient with A positive blood type until we are certain that this patient has that blood type. If this is an emergency, well, it's very easy. We could give O negative or O positive if we are not sure, and we need to release the blood right away because the patient is either bleeding or is compromised or etc. But we should solve the cases. And now if we are having a donor, this is a donor who has an ABO discrepancy, well, the situation changes, but for sure we cannot use this blood of the donor until we know what is the real blood type of the patient and why we are having this discrepancy. Now, we can start with the case number 1. These are the fun cases with the ABO discrepancies. This is a 75-year-old male patient. So we are seeing this. This was an actual case that we had at the hospital. We see, okay, this doesn't look very typical. I'm not sure what kind of blood, like what kind of result this could be. But I can have a clue. So I'm going to ask the audience, what is the most likely blood type of this patient? So we can release the next poll. So what is the most likely blood type of this patient? And we can share the results.
Sorry, yeah, just there's only 40%. Okay, we have 40% of people responding. Here we go. There we go. Okay. Oh, you can't see it. Here we go. There you go.
Okay. Well, we are having many different opinions regarding this. Oh, and I just cannot see, I cannot just take it out from the window. We are having 4% who believe it's so positive, which okay, in that case, like we are having this extra reaction here, but we are not having this typical. Let's remember, this is the forward grouping. This will be the RH, the anti-D control, and this is the reverse. So it doesn't look too much about O positive. B positive would be, but if this is B positive, why am I not having the reverse agglutination with the A1 cells, which is expected? And it could either be AB positive as well. So I will be thinking, okay, this should be between B or B positive or maybe AB positive. So it's very interesting to see that the opinions are divided 48% and 48% for B or AB. So in this case, there was a history of bowel obstruction on this male patient, no previous blood type. We had this encounter. This sample was sent to CVS and it was reported as AB positive. So this was an A2 subgroup. What happened here is that the patient had a weak forward grouping. The interesting about the ABO discrepancy cases is that when I have a very straightforward reaction, when I have a 4 cross or 4 plus reaction, then it's very likely that that type really exists. But when I have the weak reactions, even 1 or 0, that's when I have the doubt. It's very common, or I will say the most common, is to have a lack of the reverse type, a lack of reaction with the reverse type. But in this very interesting case, we can see that there's a very mild agglutination in the white and black picture. As this patient is an A2 subgroup, the reaction was not very strong. So this is an AB patient, AB positive, or most specifically, A2B positive. This was another clue, and not having any reverse reaction with the A1 cells and the B cells. And what is happening with the subtypes when I have A1 or A2 is that the antigen A can have different subtypes. A1 is the most common, let's say 80%, but 20%, around 20% of the people who are A will have A2. So in this A2, there will be a mutation in the A antigen. So the enzyme that converts the that that converts the sugar for the A antigen won't work properly. It will be hypofunctional. So the people who have A2 will have less antigen. So they have the same A. They have this, but they have less in number. The interesting is that the people who are A2 can produce antibodies against the A. It's not very common. It happens in around 1 to 8% of the people who are A2. And but it happens more commonly when the patients are A2B, let's say AB positive or A2B. But this is what we see. This is the change that we see. This is just a representation. So that first case was very interesting, and we have a second case. This was a 75-year-old female patient. This patient has been A positive in the previous historical group. How should we conclude the group of this patient? And this is what we are having. The A phenotype is A1 negative. And these patients have never received blood transfusions. And we can launch just the response. Like, what can we say? What is happening here? Okay, we have some mixed reactions. We have most of the audience believe this patient is still A positive, but maybe it's A negative, or maybe it's O positive. So what is happening? I'm having here the forward reaction. I'm having a 4 cross, so a 4 plus reaction with the anti-A, which is what I am expecting. And it looks like an A positive group, but I'm having this negative. So why am I having this negative reaction here? We can call this mixed field. Mixed field is when I have a very strong reaction with a very weak reaction, but there's nothing in between. So this is not a 1 or 2, this is just a mixed field. But what is happening? So if this patient had received a transfusion, I could believe that, okay, maybe this patient received a lot of transfusions of O red blood cells, and this can happen when the patient receives O red cells. But in this case, the patient has MDS. So this is another important cause. When we have patients who have hematological malignancies, myeloid malignancies, MDS, acute leukemia, this can happen. Approximately like up to half of the patients with hematological malignancies will lose strength in the ABH antigen, so their expression of the antigen will be less. And this is just a conversion that happens when there's a disease. The most common encounter is a mixed field or a very weak reaction, like a 1 cross or a 2 cross. We are not supposed to encounter that they are going to change the blood group and now they are going to be B. No, that doesn't happen. This is what happened. Just there's a weakness of the forward reaction. So that was a very interesting case, and we have another one, case number 3. This is a 51-year-old male patient who has multiple myeloma, and this is what I'm encountering. What is the most likely blood type? Because here looks very interesting. So what can this be? And we can release the results. What we see here in the photo is that in the gel, we're having a strong B or a mixed field in the B. For the audience, we're having the answer was B positive. This was the response. But as I said, we can just suppose what is the most likely blood type of the patient, but until we don't resolve this, we have to conclude it as unspecified. We cannot just say, oh, it looks like B positive, just let's give B positive. No, it's just that we can have a clue, but we have to do another methods just to solve this. So in this case, it looks like a B, but there's a mixed field in a B. I'm having the reaction with the A1 cells, just what is typical of the B. So what the problem is here is that I'm having a lag or a decreased reaction with the B. I'm having a mixed field. So I have some positive cells and some negative cells. Well, this case was very interesting. This was a case of a literature. They did some techniques to try to enhance it, because when we're having a very weak forward reaction, we will try to enhance, we will try to apply enzymes, we will measure this at 4 degrees, because we can have more reactions on 4 degrees. Maybe they were thinking, okay, what if this patient has maybe a B, have a reaction with the reverse typing of the B, let's enhance this. But at the end, it resulted the same. They did a flow cytometry of the case just to try to establish what the result was, and this patient resulted being a subgroup of the B. So as I was commenting before, that we have the first case, a subgroup of the A, subgroup of the B also exists, but it's very, very, very rare. But what we are going to see is something like this. If this was the case with the A, like it could make more sense because it's more common, but these cases also happen, and this is very typical to see. So in conclusion, the possible causes for lack of expected reactivity on forward typing were having antigen altered by disease with leukemia or malignancy, patients who receive a large volume of transfusion with O red cells, chimera, weak subgroup antigen that reacts very poorly with the reagent anti-A or anti-B, neonates, because what happens is that the patients who are newborns or even the elderly patients who are at the extremes of the life, they will not have a full expression of the ABO. With the newborns, this is why we don't even test for reverse typing with newborns until they are around 4 or 6 months of age, because their expression of the forward grouping is weak. So we can see, okay, maybe it's a 2 cross, 3 cross, but in the reverse grouping, it's not even reliable. They won't have even developed the antibodies at this age when they are less than 4 months old. And if they have any antibody, this could be from the mother. So this could not be a real antibody. And the other case with transplant patients who've received a stem cell transplant, they can have also a lack of expected reactivity on forward typing. So we had that case. We have the next one, case number 4. This is a 40-year-old male patient who arrived to the emergency department with abdominal pain, fever, has diarrhea. There's no past medical history. There's no any history of transfusion, and I'm encountering this. So what can this be? I'm encountering with the anti-A, actually this anti-A, there's an error here. This anti-A, I'm having a 4 cross over here. So this is a 4, not 0. With the B, I'm having a 2 cross. So this patient looks okay. It's A, have the reaction with the A, as I'm expecting. So I can say, oh, this patient looks like A positive. But what is this? What is this 2 cross that I'm having in the B? Is this patient an AB? But if this patient is an AB, then why am I having this antibody here? It just doesn't make sense. But I have a clue. With the history, this patient was arriving with abdominal pain, fever, diarrhea. So this is very suggestive of a gastrointestinal infection. And actually, this gel card over here, it's suggestive of an acquired B phenotype. In this case, The most likely blood type of the patient is the A positive with an acquired B phenotype, which is it's a temporary change that we have in the antigens of our red blood cells that happens with some gastrointestinal infection. And it's interesting. So if we have, for example, a patient who comes with a bowel obstruction or with a rectal carcinoma, or just a gastrointestinal infection for E. coli, Escherichia coli, or Proteus, these bacteria can enter to the bloodstream, and this can cause, if the patient is A, this can cause a change at the end of the epitope and converts the N-acetylgalactosamine and just convert it to galactose. So we will have this change temporarily in the blood type of the patient. Or if the patient is O, it just can make a change and just have a new reaction here. But what am I going to do to solve this case? Well, I have the history. I know that this looks very typical. I will have to make a study just to make sure if this is the real group of the patient, if this is not another thing, how is the control? Is this rouleau? Is this fake? So this is what happens here. This is a typical case of a patient with acquired B, which is a temporary condition. But this patient, even that he has this change, we cannot give B positive blood cells because this patient has still the anti-B present. So if we give B positive cells, as for the transfusion, it will be a chaos. We will create a hemolytic anemia and it will be very bad. But it's another interesting case of ABO discrepancy. When we have an additional or unexplained reactivity in the forward typing, we can have these possible causes. The acquired B antigen is one of them, as the case that we just saw. We have the transplantation, autoagglutinins, or excess protein coding red cells, which could be patients with myeloma, unwashed red cells with plasma proteins, the same, or antibody in the patient's serum to reagent constituent. Sometimes when we have this case, we just have to repeat the test with another reagent because maybe it's a problem with the reagent, and then we try a second brand because it will be very unlikely that the second brand will have the same substance that is provoking this reaction. It can be an out-of-group transfusion, but in this case, it wouldn't make too much sense because we won't be transfusing a patient who is A, we won't be transfusing the patient with B, or polyagglutinable disease. Polyagglutinable disease is a condition where the patients have agglutination with almost all kind of serum, but these are patients or people who have anti-I, and this is produced for just special conditions that we have the reaction to almost all the red blood cells and all the serum of the other patients. This is very rare, but it can exist. And this can be either a temporary condition, or it can be an acquired, or it can be hereditary condition. Case number 5. We are encountering a 55-year-old female patient with diffuse large B-cell lymphoma who received an autologous bone marrow transplant 3 months ago. What do we think that this reaction could be? That this ABO type could be? So we're having, there's a strange A. So there's an anti-A, A positive, but like, wait a minute, where is the B reaction that I need to see just to be certain that this patient is A positive? I'm having this ABO discrepancy. What is happening? Well, the history can give us a clue that this patient received a bone marrow transplant and it was autologous. So in this case, all the audience believe it was A positive, which was great. In this case, I'm having condition that is producing an immunologic deficiency on the patient. So the antibodies in the patient won't be reacting properly because the patient is immunocompromised. And this is another condition that we have to search to see and to think about. We're having here lack of reaction in the reverse typing. And I could say that this is the most common type of reaction that we can encounter. because we have so many patients who are immunocompromised. Reverse reaction not showing, but the patient records show that this patient was A positive, and we can guide ourselves with the records and be able to transfuse A positive red blood cells to the patient. The possible causes of lack of reactivity in the reverse typing, we're having the transplant, hypogammaglobulinemia. We also have the neonates or the elderly. As I say, we don't even do reverse typing in neonates. Deterioration on antigen expression on reagent red cells with storage. So this will be those reagents if they have 6 months, well, a long time, let's say 1 year or months, they just expired, then they won't be reacting well. Or this could be chimera. This is another case that I'm having the contrary. I'm having here like, oh, there's a reaction with everything. So what is the blood type of the patient? I'm having A, B, but I shouldn't be encountering D. So what is going on? This was a 43-year-old male patient. The patient group was AB positive, and this was a patient with T-cell lymphoma who received an autologous bone marrow transplant with an associated cold autoantibody. So this case, I'm going to guide myself that as the reaction with the forward typing of the A and the B was very strong, this is very likely to be A positive, and I have just to solve this. So the audience here did very well, 91% thinking this is an AB positive case. A clue that I have here is that the control is having a positive reaction, and the control is just the red blood cell of the patient with the same plasma of the patient. There shouldn't be a reaction there. So, okay, this can either be Rouleau or a two-cross reaction. But as I see this, I'm going to try to solve. I have the history that this patient had a lymphoma, so maybe the patient has an excess of proteins in the plasma that is causing me this fake reaction. But until I don't solve this, I cannot be certain. In this case, this was a case of Vancouver General Hospital. We needed to pre-warm the sample and do a saline replacement just to wash these excess of proteins and just to give the real results. And the patient resulting being AB positive, and after the washing, the saline replacement, this did not appear. And now this. So case number 7, 45-year-old female patient who has a pre-surgical workup for elective surgery. What is the most likely blood group that I have here? I have a strong A, strong B, but I'm having a 2 plus reactions with an anti-A. So what is this? This case, okay, some people believe this could be an A positive, which could be like, okay, I could believe like, oh, well, if this is A positive, why am I having the B positive reaction with the forward typing? Why am I having the A1 here? This just doesn't make sense. Well, this is again very similar to the first cases that we were discussing in this presentation. This is very common. This is a patient who just have an A subtype. So patient has A2B or AB. It's an AB positive patient. As I was mentioning, 1 to 8% of the patients who are A2 will have antibody against A1 blood cells, and around 10% to 45% of the patients who are A2B will have antibodies against the anti-A1. If this antibody happens at, let's say, at cold temperature, then it doesn't matter. We could still give A positive blood cell, or in this case, like AB positive or A positive. But if this reaction still happens at 37 degrees, then for sure we won't be able to give any red blood cell that contains an A antigen. So in the additional or unexplained reactivity or on reverse typing causes, we have cold autoantibodies, cold reactive alloantibodies, serum antibody to the reagent constituent, passive transfer of antibodies due to recent transfusions of out-of-group platelets or IVIG, excess serum protein, transplant, or subgroups. And this case, it was another case of a healthy 25-year-old male that we were seeing two different groups of the forward type of the anti-B. So there's a mixed field here, but the patient still produced the anti-A. So this was a very special case of a dispermic chimera. If we encounter one case with this, we will have to publish it because it's very, very, very rare. But it's one of the causes of mixed field that we can have. So in mixed field red cell activities, we can have ABO subgroups, recent transfusion, transplant, fetal maternal hemorrhage. Let's say if the mother is A positive, but the baby is O positive, and there's a fetal maternal hemorrhage, I can have the mixed field, or the very rare cases of chimerisms of twin or dispermics. And in these bonus cases, that this can happen as well, we can have this was a case of a 50-year-old female patient coming with hypothermia, but the historical charts show that the patient had a negative blood group, and now she's arriving with these results. Is this an ABO discrepancy? Patient was A negative and is arriving with this. So what do we believe? I would like to see.
Just letting people do. We have 28%
Yeah.
going
So I'm
up.
having this. Patient was A negative, arrived with this. Is this an ABO discrepancy?
Keep answering people, yes or no. I know some people might not still be in the room. Okay, I'm gonna end it at 44, 46. Here we go.
Okay, most of the audience believe this is at 74%, but this is not actually an ABO discrepancy. Because in the definition that I said is that when we have a discrepancy with the forward and reverse reaction, but this is not any discrepancy. This patient is O, and I'm having this very strong reaction with the reverse group. So this is an O positive. This is very suspicious, especially when there's not any other cause. Now, in this history, this patient was just arriving with hypothermia, but she did not have any transplant. She did not receive any transfusion. There's not any explanation, like why will the patient acquire now an Rh positive? And this doesn't have any sense. So in this special case, patients say that this was herself, because what we do usually is just to recollect the specimen, check the ID. But what happened is that this sample was sent to CBS and there was no serological evidence of ABO discrepancy. So given the discordance with the historical results, it was a discrepancy just with the historical results. At the end, the patient admitted use of somebody else's ID. So this is something just to have in mind. We can suspect it, especially when there's not any explanation at all, and this is suspicious. But still, we just have to repeat the sample. We just have to make sure that we are not committing any technical errors, because technical errors can happen. There can be a specimen mixed up, or too heavy or too light red cell suspensions, or maybe I forgot to add the reagents of the anti-A and anti-B in the reverse reaction. Or maybe there was hemolysis, but the hemolysis can be very, very mild, and maybe there's no experience how to report the hemolysis. Maybe I did not follow the instructions, or there was an incorrect interpretation or recording the test results. How can we have a resolution for these ABO discrepancies? First, we repeat the test, we test a new sample, wash the red cells, we test for unexpected red cell antibody. Let's say that the patient has an a red cell antibody to for a high incidence antigen. We check the patient's medical record. That's the first step. If we are having that there's a weak or missing antigen antibody, we have to enhance the reaction. We can add more plasma if this is the problem for the reverse reaction. We can incubate the red cells at 4 degrees because the antibodies, the antigen antibodies binding will be better at colder temperatures. We can use enzymes, we can conduce adsorptions, or even molecular testing when this is needed. If we suspect that this patient can be an A subtype, there is a lectin that is called Dolichos biflorus that it agglutinates only with group A1 patients, but not with A2. And this can confirm, oh yes, if there's not an agglutination here, well, the patient is not group A1. Or if we are thinking that there is a problem in the reverse grouping because there are extra reactions, we can have an autologous control at room temperature, or if there are cold antibodies, we can test this at 37 degrees. Or if we have rouleau, we will suspect this because the control will be abnormal. And the best way to solve it is adding saline replacement or saline dilution, and this will help to distinguish rouleau from agglutination. Okay, thanks. This was the presentation, and then now we can just discuss, and if somebody has any question, we can just go through it.
Thank you so much, Elsie. I'll open it up to the floor to see if anybody has any questions. Seeing from Dr. Smith that he loved the interactive cases. I agree.
Oh, thank you.
Yeah, it wasn't that hard actually to do the polls on my end. So happy to have that included for all future rounds. I know because I cannot share the Zoom link to have someone a co-host just with the UBC Zoom link, then I actually have to create all the polls, but happy to do so if because it did bring a lot to the presentation. A question about getting a copy of the slides. Are you willing to share a copy of your slides, Elsie?
Oh, sure.
Yes.
Yes.
Okay, I can send them out to the group. So Kara, do you have a question?
Yeah,
Or any
so
comments?
first, hi. So great presentation, Elsie, and you look amazing today. I have to say.
Thanks.
Yeah, so maybe we learned from the audience because we were away, like we had been with solid phase for a while, and then since the spring of last year when we switched to gel, there was a big learning curve of all this, additional reaction and have to do a lot of manual just trying to, get rid of extra reaction. Is anyone else that using, I don't want to advertise them, AutoVision Max Swift or whatsoever from other side that experience the same thing? Because obviously it's just so sensitive. And then if it leads to a lot of the additional manual tests, then yeah, it's something that, we have to think about. But yeah, we had shift to gel. So now I think we get better over time. Yeah.
Yes, it's very interesting, but we still need to know how the reaction is with the solid phase, and it's very important because it's very different to the tube. So, but yes, VGH is not using it anymore. We have switched to gel cards over there.
There's a question. Sorry. Yes, comment. A surprise that the acquired B was detected by the monoclonal anti-B.
Yes, that was a good point. Yes, but there was a mixed field reaction. I don't know, in the acquired B there was no mixed field. It was a 2-cross reaction. So it was a weaker reaction. It was surprising, but it happens. It happens, and that's the typical reaction that we have. It's a weaker one. But yeah, monoclonal anti-B in a patient who has GI symptoms, but the patient still will have the anti-B in the reverse grouping, so we cannot just give now B positive red blood cell because that would be very bad. A very interesting case.
So my comment or question for you, Elsie, is so in some of these cases, like which kinds of these cases would you feel comfortable giving the blood group that we expect versus, giving group O?
Oh, I will feel comfortable is reviewing the history of the patient. If I see that the patient did not have any transplant, because in transplant we have special rules, and we expect that there will be an engraftment, and we have to follow up just the recommendations for this, which is different. So if we have a patient who has a record history of a certain ABO blood type, and there's an explanation that makes sense, maybe in the lack of the reverse reaction, because maybe the patient is immunocompromised now, I will be very sure to give the expected red blood cell. And also, after ruling out other causes, we still have to rule out that we had a technical error. So we still have to repeat the test. And I will also be very certain to give the red blood cell if I'm seeing a rouleau, or in a patient who has a multiple myeloma, there are extra proteins. And if these reactions clear after doing the saline replacement, I will also be very confident to give the ABO.
Perfect. Now, in that last case, that it was not technically an ABO discrepancy, but it was a historical discrepancy. If they needed blood before we found out this history that they actually used someone else's card, what do you think you'd do? It's always the tricky one, right?
That was tricky. Before resolving it, I will just give O. I will not risk it. I will give O.
Yeah, I agree. That's the tough part because, you can repeat the sample and then, well, I guess there's a chance that one's also wrong patient. So,
yeah.
But we have had a few cases, where there have been probably people using other cards and they don't admit to it. So it'll happen from time to time.
Yes, that case was it was a recent case, actually.
Yeah. And then always the wrong blood in tube, from trauma patients or something that it really doesn't fit, that they accidentally sent the wrong patients. If there's 2 trauma patients, we've had a few times too. Okay, well, it doesn't seem like there's any more questions. Oh, here we go. There is one. For acquired B, how often does the A antigen become totally undetectable on forward group? No reaction with anti-A, such as in the case.
Oh no, there was an error of the typing. There wasn't a strong reaction. There will be a strong reaction for the acquired B. There won't be a lack of A. Like the patient will still have A positive red blood cells. It was a 4. I mean, I know I typed 0. It was a typo. It was 4 because it was a very positive forward reaction. So it's not common to find that the patient will lose the A antigen to become undetectable. That's not common. That can happen when we have an acquired an A2 subtype, that we can have a mixed field or maybe a weaker reaction, or when we have a patient with a hematological malignancy but with acquired B. If the patient was A, then the patient should still be looking as A in the forward typing. It's just that there will be a weak B.
Perfect. Okay. Yeah, it was just a typo.
Thanks.
Yeah, I'll change that before we send it out.
Thank you.
Yes, no problem. Okay, well, thank you so much, Elsire. That was amazing. Great overview, and I loved the interactive cases as well. So I'll be sending out information soon, hopefully for the next rounds. So stay tuned for that. Bye, everybody.
Thank you very much for attending. Bye. Thanks.
Bye.
Have a good day.